My name's Carrie Siegel, and I'm a professor of radiology at Washington University in St. Louis. I'm in the abdominal imaging section, and my area of interest is genitourinary radiology. How do we use CT for staging testicular cancer? And what we use, there's different staging portfolios, but we tend to use the tumor node metastases staging system, the TNM. And the reason why I'm saying that is when we talk about the T stage first, I'm going to slightly diverge from the subject matter to talk about ultrasound for 1 minute, and then I'll spend the majority of my time talking about how we're using CT. So when we're staging a testicular tumor, it's really critical for the provider who's ordering the exam, because the stage of the tumor and the type of tumor, those two factors are really going to indicate management. So I'm just going to talk about ultrasound for 1 minute. We stage the primary tumor in the testes with ultrasound. And the T1 stage in ultrasound is the tumor is confined to the testis or epididymis. T2 is the tumor has breached the tunica albuginea. And as you know, the tunica albuginea is this sort of tight vest or jacket around the testes that keeps it in that ellipsoid shape. A T3 tumor extends beyond the tunica albuginea into the spermatic cord, and a T4 tumor actually extends to the scrotal skin. So for T staging, we use ultrasound. Now I'm going to switch gears and go back to the question at hand is, how do we use CT for staging? The rest of the staging, the N and the M staging, will be done predominantly with CT. Occasionally people will use MR or PET, but predominantly CT. The majority of referring doctors are going to order a CT of the chest, abdomen, and pelvis. Some providers will alternate ordering an abdomen and pelvis CT on one cycle and a chest, abdomen, pelvis on the other, probably to just decrease radiation dose. On the chest portion of the CT, we're going to be looking at lymph nodes and pulmonary nodules. Now, there are many lymph nodes and pulmonary nodules in people that do not have malignancy. So these lymph nodes and pulmonary nodules need to be in a detailed way measured, characterized, and compared to prior studies. I'll come back to that in a minute. For the abdomen and pelvis CT, we're going to look really carefully at the retroperitoneum, because that's the #1 landing spot for metastatic disease in patients with testicular cancer. By definition, we have used lymph nodes greater than about 7 or 8 millimeters as positive for a lymph node on CT. Is that perfect? Absolutely not. And I'm going to talk about that more in a minute. People have looked at different studies where they've said, well, let's just look at lymph nodes greater than a centimeter. Well, that's great because you're going to have great specificity, but low sensitivity. And then people have suggested, well, maybe let's look at 4 millimeter lymph nodes where you'll have great sensitivity. And again, the specificity goes down below 60%. So the magic number from many radiologists who have looked at this is a 7 to 8 millimeter lymph node. That's in short axis. Once we determine that, a lymph node is considered positive. Other features that we're going to look at in terms of the lymph node are, one, is the lymph node homogeneous or does it have central necrosis? We're going to look at the margins of the lymph node. Are the margins smooth or are they spiculated and irregular? We're going to look at the shape of the lymph node. Is it oval or elongated, or is it round? And one other feature that I look for that isn't part of the necessarily documented criteria in the radiology literature is I look for lymph nodes that are coalesced together. What I mean by that is if we're using 7 to 8 millimeters as a size cutoff for positive, every once in a while I'll see a patient that'll have 4 lymph nodes all clustered together in a small space. that are 5 millimeters in size. That doesn't meet size criteria to be an N1 lymph node, but those bother me and I tend to mention them. I don't stage it as N1 disease, but I mention it and it gets into my impression. And my experience has been a lot of times providers, when they read that, if they were going to get a 1-year follow-up, they might get a 6-month follow-up. They might just take that information with the tiny lymph nodes that don't specifically meet size criteria and maybe adjust to a shorter follow-up. So that's what we use for lymph node measurements. What's important is when we're doing close interval follow-up is sometimes we'll identify a tiny pulmonary nodule, 2 or 3 millimeters. So the question is, was it seen on the prior study? If it's seen on the prior studies, we're clear it hasn't changed. But if we don't see it on the prior study, there's 2 options. 1, it wasn't there on the prior study. And 2, because it's 2 or 3 millimeters in size, we could have just missed it with their slice thickness. Or if we're looking at a little 3 millimeter liver lesion, we could have just missed it either because of slice thickness or because of the exact bolus of enhancement. So the radiologist really needs to go back through multiple priors to ensure that that pulmonary nodule or little liver lesion is new or is not. It sounds like a lot of time. It's really not. We call up all the prior studies. And if there's one new 3 millimeter nodule in the right lower lobe, I'll just call up all the prior studies and quickly run through them. The other thing that the radiologist does is we really spend about 5 minutes just reviewing the old study, making sure we have all the landmarks to do a really thorough evaluation of the new study. Most of the CT scans done for staging for testicular cancer are going to be done with intravenous contrast. I would say, at least in our institution, most are not done with oral contrast. Now, as you know, sometimes the third and fourth portion of the duodenum can sort of really dip or invaginate in between the inferior vena cava and the aorta. So every once in a while, a patient will need oral contrast, but I would say it's less than once a year we need to bring the patient back and really sort of what we call flood the bowel, really give a big bolus of oral contrast and rescan. Every once in a while, there'll be ambiguous or uncertain findings, which may require some other imaging or close follow-up. Some of the small liver lesions may require follow-up, or if they get a little bit bigger, to a centimeter, an MR. And again, the pulmonary nodules, we're going to just closely follow over time, back to all the prior scans and going forward on subsequent scans. At the end of this whole assessment, when we've measured all the lymph nodes, for our end staging, N0 are no worsened lymph nodes. N1 are lymph nodes less than 2 centimeters. N2 are lymph nodes 2 to 5 centimeters. And N3 are greater than 5 centimeters. Now, the TNM staging for lymph nodes, they use long axis. But if you remember, I mentioned even be a positive lymph node, radiologists use short axis. So all of our lymph nodes are going to at least be 7 to 8 millimeters in short axis to get even as a positive lymph node in the first place. And I just want to reiterate one more thing, that for M disease, M0 are no metastases, and M1 is metastatic disease, and that includes lymph nodes outside of the expected landing zone. So supraclavicular lymph nodes, pelvic lymph nodes, pulmonary nodules, really bone mets, even brain mets are all going to be in the M1 category. So that's how we stage testicular cancer. A good quality CT, IV contrast, a very, very thorough look at the prior studies, and that's including all pulmonary nodules, and a really discrete look at the retroperitoneum. At the end, we're going to come up with a conclusion. The lymph node status or burden of disease is better, it's worse, it's stable, and very rarely there will be discordant findings where lymph nodes in one area will be getting bigger and pulmonary nodules in another will be getting smaller. That doesn't happen very often, and we usually just report it out that way. But the majority of the time, we're able to say whether disease is improving, worsening, or stable. And again, a very thorough look at the retroperitoneum, both the periaortic, the pericaval, and that whole interaortic cable running up and down the retroperitoneum.